in particular the colostomy stopped him from doing his normal work. It took over his life. He couldn't take his little daughter to the swimming pool because he felt embarrassed with the colostomy. So he was very keen to start with, to get into the procedure, and he was very positive afterwards. He was very good. We were able to close his colostomy at 6 months after the procedure. At 3 months, we found that there was no residual tract and no fistula, and then reversed his colostomy, and he was here for his life back entirely. Well, it's not all that good. These are our results on the 7 patients with cryptoglandular fistula. We've got an overall initial closure rate of 70%. It seems to be the magic number for fistula treatment. People do seem to get to 70% and not more than that. 2 patients haven't healed. Now this gentleman, we ultimately treated with a cutting ceton, and he had then a complete closure after some time. He was remarkably big. His BMI was 40, so it was rather big. One could speculate that the amount of fat we took was not enough to give enough cells, if we think the cells have been the crucial factor. This lady is a young girl, who had a very long tract with the external opening anteriorly in a paralabial position, so very long perineal tract. We injected that long tract, but unfortunately it did come back, possibly due to infection which has been lingering on in the area of the fistula. We have since shortened the tract by laying open the perineum, and now have got a short transsphincteric tract, which we are hoping to possibly re-inject in the near future. So you've got a ceton in at the moment, but the tract is considerably shorter than there. We have treated 1 patient with Crohn's disease, a 34-year-old male patient who has a long-standing Crohn's disease. He has an ongoing pancolonic Crohn's disease. He was diagnosed initially in 2003 with an anterior fistula in anus, started on immunosuppression, ended up on biological treatment there, on infliximab. Had a very long tract there on the MRI, and then underwent the treatment. This was our technique. In the same way as the excision of the tract and the injection and bulking. Well, unfortunately, there was no sign of healing at any point. 10 months follow-up, the fistula did persist, and he developed, in fact, further posterior fistulation at the point with flare-up of colonic Crohn's. He continues on medical management, and we have discussed him in our multidisciplinary team, and he's coming closer to think of panproctocolectomy and ileostomy ultimately. We have tried a rectovaginal fistula in a 63-year-old female who had a previous resection rectopexy, which then 2 years later fistulated. She failed vaginal flap repair. The investigation showed a very short fistula tract, and we took her on for the ADRC treatment. We were able to bulk up the rectovaginal septum quite significantly to quite significant thickness, closing the vaginal flap. But unfortunately, after 4 months, she had a clinical recurrence. After 3 months of stable disease, so there's no fecal material PV. So the non-cryptoglandular fistula were less encouraging. Overall, the procedure, the liposuction definitely was well tolerated by all patients. The slow vascular function processing and reinjection had no adverse events, and no new or significant incontinence did result from our treatment. And in the cryptoglandular group, we put a 70% healing rate, which is plenty promising. In conclusion, bone marrow stem cells, and particularly adipose stem cells and regenerative cells have all been used now in the treatment of complex fistula in ANO. It is particularly the ADRC, the stomach vascular fraction lab filling, is a safe and real-time application which does not need the lab-based in vitro cell expansion. In the cryptoglandular group, it might demonstrate some promising results. In Crohn's and other diseases, it has been, in our experience, less effective. Further investigation is planned and underway to, at the moment, expand our study, and also to potentially set up a multi-center study within the EU on cryptoglandular fistula, focusing on cryptoglandular fistula, and we've identified centers in a number of EU countries who are keen to collaborate. And these are my colleagues, an oncoplastic team, Mr. Basket in particular, who has been very helpful in setting up this idea. Oh, thank you.
Can I ask you a question? My name is Professor Geçim from Ankara University, and thank you very much for your very interesting and excellent presentation. A couple of questions. Any interaction with stem cells, or whatever you call, and the immunosuppressive treatment when you inject for Crohn's disease? This is the first question. So this is actually, I'm planning to start with the very old, couple of years patient waiting, trial any kind of surgery like the ones in your testimonial history. So if we inject, should we stop the immunosuppressors to get a chance for stem cells to grow?
With a limited experience, I would feel, my personal feeling, without being able to prove it at this point, is that the immunosuppression is quite possible being part of the reason why the cells have not worked, in this one case which we had on immunosuppression. It would be good to have some in vitro work, or in the animal lab to do some work on that. Well, on this question, yes.
Okay.
But I can't give you the answer on a scientific basis.
Can I take some more time if there's no more questions? Well, how about talking about the risk of cancer in those cells? I understand it's going to grow without any control. So immunosuppressive plus uncontrolled or possibly uncontrolled cells at the same place. Would you think it causes any further risk of cancer development for the patients already under immunosuppression?
The experience from, in particular, with breast cancer patients, that seems to be the biggest group of patients we've got experience with, seems to show that there is no increased risk of cancer. And in particular, if we're treating an area where there is no previous cancer, there's no anal cancer or colorectal cancer there, I would think that the risk is not in, it shouldn't be in, it won't be affected there either.
What I'm trying to ask is, if you inject the cells through the fistula tract, am I correct to understand that?
Yeah.
You get into the tract and then inject it on the walls of it, correct? So, how about those cells? Do they stop proliferating when the fistula is closed, or what happens to them? And on top of that, if you give immunosuppression, how do you control? How do they stop? Is that a genetic code or what?
The cells do differentiate into the tissues where in the host environment. They don't overgrow. They're pruning themselves. There's no evidence of an overgrowth in my experience. In your experience, I think there is also no experience that there is any overgrowth or change into cancer cells. Or,
Very shortly, just sorry to interrupt. Basically, these cells, what you get from the fat, are actually sleeping cells. So our problem is not to control them. Our problem is to wake them up. When you inject these cells into an area, the basic trigger there is going to be hypoxia or wound healing. And as long as those triggers are gone, so the wound healing process is over, those cells automatically go back to sleep.
Okay, what I'm trying to figure out is how are we going to consent the patient for the liability? Am I going to put a sentence there if a cancer or anything develops in the future? So I'm informing you about that. Should I put that sentence in the consent form? That's what I'm trying to figure out.
I wouldn't say there's any evidence on that you need to put that onto a consent form. The risk would be minimal as far as we know, and there's no evidence to say that you should put that onto the consent form, I would say.
Okay, thank you very much.
Thank you for your excellent presentation. My question is, you are using standard stem cells, right? No any pre-treatment, right?
We use the ADRC fraction, stromal vascular fraction. So we don't extract the stem cells, we don't go further and culture or enhance the stem cell fraction. We use a fresh stromal vascular fraction, so the cocktail of cells which include stem cells, but also a lot of other progenitor cells, blood cells, and macrophages, tissue macrophages.
Right. Those cells are multipotent stem cells, right?
They're multipotent.
If you use any pre-treatment to drive the cells to any way, like the fibroblasts or something else, or any cells may help the healing. Is there any way such a pre-treatment to get better results?
We don't know. I couldn't answer this question. We've developed our technique on the background of plastic surgery, oncoplastic surgeons who've been doing the lipofilling for the breast, and we know the effect of the stem cells in the fibrin glue, which seemed to have been promising, and that is where our concept came from. So we use strictly the pure cells without any manipulation, pre-treatment. It would put us also into a more difficult situation. We are not a lab-based hospital, so we've been focusing on the treatment which can be done in the operating room without the regulations of the Human Tissue Authority and so on, which would then require us to have a completely different set of standards. It's a bedside treatment or it's an operating room treatment within the same day, and that was our focus, that we wanted to do a very practical way of using the cells.
Actually, I also wanted to ask two questions, but just a comment on that. We believe that we know less than nature. Basically, the wound healing process is a very complex procedure, and putting some cells which are devoted to only a single methodology, let's say fibroblasts, would actually decrease your ability to help the body to help itself. So injecting the area with stem cells, which are going to be capable to turn into anything what is needed there, would be probably more suitable. And my questions would be like, why were you injecting so much fat? Because you have enough trigger there, so you don't need actually a very distinct amount of scaffold. So you might use less fat and have a concentrated tissue there. That's the first question. Maybe you have to consider about that. And the second thing would be, what is the reason of your failures in the treatment? And maybe it's supposed to be considered as well. If the failure rate is dependent on something which is happening on the second week, then you might postpone the stem cell injection to that point, not to initiate surgery.
Yes, I've tried to, to your first question, the principal idea was that we wanted to increase or decrease the risk of recurrence by getting rid of any focus of infection in the middle of the tract. Because what the problem is with fistula is persistent of infection somewhere, and if there's an infection in the middle of the tract and we achieve closure or partial closure on either side, then the infection can fester away because it is a little contaminated tissue from the start. We do freshen up and we do clean up as much as we can, but the failure is usually due to the recurrence of infection and then the infection breaking out to either side of the fistula. So that is the enemy, if you want. And the idea was that we compress the tract completely so that we get rid of these dead spaces while they were as clean as possible at the time of the debridement. So that was the idea where we came from. The failure in the cryptoglandular group, if you can focus on that, I mean, I've tried to point out, I mean, the one patient who, the male patient who failed, he was a very big gentleman, and the liposuction might not have revealed enough cells. That is my personal thought on this. The other lady had a very long tract, and I think the thing going back to your first, first question, did apply that she had about a 9 or 10 centimeter long tract through the perineum, which probably had some infection somewhere. We didn't close the whole tract, and it just festered away and opened up again. And the idea is now that we've shortened the tract around the sphincter muscles. We've only got a very short tract now to deal with. It was like with most of the other patients, and then have another go at this one to try to close it.
I have another question. In these procedures, it is likely that you can repeat the procedure again in a short time, or it seems so. And practically, what will you think to repeat the cell procedure again each time, or will you freeze the amount from the beginning?
We haven't got legal, you haven't got a legal situation to store at the moment. There is a setup of tissue banking in the UK at the moment, which is talked about, but we haven't got a tissue bank, and certainly our hospital hasn't got the currently the facilities of having tissue banking. So at the moment we are limited to what we can do at the bedside in the operating room. So a very practical aspect rather than, but it would be ideal if we could have a tissue bank. That would be great. But at the moment we don't have the setup basically or any legal situation on that.
Okay, thank you very much for this very nice talk. We appreciate you share your experience with us. Hope to see you again. And şimdi biz bir yemek molası vereceğiz. Sizi ağırlamak istiyoruz. Yukarı, karşı binada yemeğimiz. Size arkadaşlarımız yardımcı olacak. Saat 1.30-2 arası burada olursak 2'ye çeyrek kala ikinci session'ımız başlayacak. İlginç bir sunum olacağını tahmin ediyoruz. Çünkü klinik tecrübeleri sunacak doktor arkadaşlarımız değişik konularda ve interaktif bir tartışma ortamında geçmesini istiyoruz. Hepinizi bekliyoruz. Afiyet olsun.